Hello, nurses. This is Lisa. We have a podcast for loss and grief. So, when we're talking about loss and grief, we have to remember that those can affect somebody's health physically, psychologically, socially, and spiritually. We see patients with losses and who are grieving. And we also have to remember that as healthcare professionals, we also have those losses and we grieve for our patients as well as having our own family losses. And we know that we need more knowledge about end of life issues, and so do our patients. So, our objectives today are to discuss categories of loss, types of grief, and theories related to loss and grief. Discuss variables that influence a person's response to loss and grief. Differentiate the principles of palliative and hospice care. Apply the nursing process in the care of a patient and family members experiencing loss, death, and grief. So there are different types of losses. The first one we'll talk about is maturational loss, and that is just part of normal development, normal growth and development. And these types of losses generally can help people cope with change. So an example of maturational loss would be parents who send their kids off into the world and they feel a loss of their family. A perceived loss is defined by the person experiencing the loss. This is often less obvious to others and may be misunderstood, but it is real to that person. This can include inanimate objects. It can include real objects, something like self-esteem or ego. So even though the patient might be grieving and it seems to you like not a big deal, it is to the patient. Necessary losses are a part of life. They cause us to undergo some type of change. When a loss occurs, oftentimes it can be replaced by something different or better. So, for example, when you think about your time during nursing school, you have some necessary losses of some family time, some friend time, that type of activity. However, once you graduate from school, you will be moving on to something better. And again, this type of loss could be something that is an object. It could be a person. It could be time. An actual loss occurs when a person can no longer feel, hear, or know a person or object. So this would be a death of a person, loss of a limb, death of a pet or a friend, or even loss of a job. So when the object of the loss is no longer available, that is an actual loss. A perceived loss is defined by the person experiencing the loss. So again, this might be less obvious to others. A situational loss is sudden and unpredictable. So this would be, for example, a divorce would be a situational loss. Something that is a big loss at the time and can result in a change. But divorce only lasts for so long. So it's situational. How one interprets the meaning of any loss as well as the type of loss affects how someone grieves. And you have to remember it's about the perception of the person who feels the loss. Some people are very connected to their pets, for example, and somebody might come and say, "Oh, my dog died," and they might be completely devastated, whereas somebody else might just say, "Oh, my dog died," and it's not as big of a deal to them. Just some vocabulary. So, grief is the emotional response to a loss. Mourning is the conscious and unconscious behaviors associated with the loss. And bereavement includes both the inner and outward behaviors of a survivor. People respond to grief in different ways based on their experiences, their cultural expectations, and spiritual beliefs. Many theorists describe the grieving process that occurs with any loss, including death, chronic illness, or sudden loss of body function. There are several classic grief theories that describe commonly experienced psychological and behavioral characteristics, and we'll get to those soon. There are a couple of things that can help us with grieving and loss, and one is reminiscence, remembering good times before the loss, can often help people with their grief. And then what we call resilience or toughness, the capacity to recover from a loss, is also going to help determine how somebody deals with grief. I did want to mention here that there is an organization called the Endoflife Nursing Education Consortium, and this is a project to improve palliative care around the world. And when we think about healthcare professionals that spend the most time at the bedside with patients, it is nursing staff. And so it could be nurses, nurse assistants. There's other people on that spectrum, but nurses are the biggest professional that's supporting their physical, psychological, social, and spiritual needs. And the research indicates that a lot of nurses do not feel competent or confident to be able to provide this type of holistic end-of-life care for patients and families. And so when we're talking about that holistic end-of-life care, we could be talking about palliative care or hospice care. And remember that palliative is different from hospice care. They both provide comfort and treatment of symptoms of whatever the disease is. But during palliative care, a patient can also receive curative treatment, whereas in hospice care, all curative therapy is stopped and the symptoms are addressed. So this is different from something, say, oncology nursing is, you could have palliative care or hospice care as part of oncology nursing, but it is different. And so I wanted to make you aware of this end-of-life nursing education consortium. If they do have, if you're interested in hospice nursing, or just if this is a topic of interest of you, they do have modules or online classes that you can take, in your spare time, once you're working and no longer in school. So when we're talking about one of our professional standards when we're dealing with end-of-life issues is a Bill of Rights for people who are dying. So the dying person's Bill of Rights. And the guidelines for care of elderly at the end of life are offered by the National Institute of Health. And those rights are pretty simple: to be treated as a human being, to have hope, to be able to express emotions and feelings, to participate in decision making in healthcare, recognizing when the goal to cure something is changed to the goal to comfort, to not die alone, to be free from pain, to receive honest, non-judgmental care, respect for the body after death, and the caregivers often gain satisfaction because they have helped somebody face death. And we can always, when we're talking about helping patients who are having illness, sometimes we need some tips, and you will see in your Moodle that you have some tips for talking with dying patients. And I'm going to actually switch over to that in this podcast. Many people worry about how to talk with someone who is dying. Remember that your caring presence is more important than saying the right thing, and listening may be more comforting to a patient than you trying to make conversation. What you can do to provide emotional support: know your patient's history, if death is expected to be soon, and be aware of his or her preferences for care at the end of life. Let the patient know that care is focused on his or her wishes, and the team will do their best to honor the wishes. Listening is an important part of communication and requires your full attention. It is important to give the patient time to share his or her story. Helping the patient review his or her life story may help resolve past conflicts and foster forgiveness and inner peace. Encourage the patient and family to express their feelings. Be prepared for a range of emotions such as anger, sadness, anxiety, or fear. Try not to be angry, judgmental, or be offended by what is said. Be honest. Some patients may ask you, "How much longer do you think I have?" And if they do, you can ask, "Tell me more about why you are asking this question. What are you thinking? What are you feeling?" Since no one knows the exact answer, ask the patient what they have heard. Reassure the patient that a team member will follow up with them and inform the rest of the healthcare team that this question has been asked. Help the patient maintain a realistic sense of hope, even in the midst of dying. Reframe hope by helping the patient hope for a good night's rest, for better pain control today, or for the chance to see grandchildren one more time. You're making those short-term goals. For some people, a way to communicate caring support may be with loving physical contact, such as holding hands, hugs, or gentle massage. Remember to ask permission before using touch, as some people may feel uncomfortable. Often, patients may talk to or see people from their past who have already died. This is normal and should not necessarily be dismissed as agitation. As death approaches, a patient may withdraw from everything outside of him or herself in an attempt to cope with the many changes that are occurring. Withdrawal is a part of the natural dying process and usually does not mean the patient is depressed or upset. Help family and friends understand that this process is expected and normal. So the first theory we're going to talk about today is probably the most famous one, and this is Elizabeth Kubler-Ross's Stages of Grief. In the theory world, it's not that old. It was developed in the late 1960s. And these stages of grief can be used for people who are grieving a loss that has already occurred. It can also happen for somebody who's in anticipatory grief. So if we know that somebody is dying but they haven't died yet, these stages would also be appropriate. And the stages are denial, anger, bargaining, depression, acceptance. And maybe if it helps you to remember that by using the acronym DABDA, that is a pretty famous acronym. And one thing about these stages, and this goes for the other theorists as well, is that people don't go through these stages in linear order and get to the end and be done. Sometimes they can skip a stage, sometimes they can slide back and forth between them, and there's no prescribed time to get through any of the stages. It all depends on the person. So let's talk about denial. This would be they're just acting as though nothing has changed. They can't believe it or understand that a loss has occurred. So sometimes you can picture somebody when they hear a piece of bad news, their first reaction is, "Oh, I can't believe it. I just saw them 2 days ago." That would be an example of somebody in the denial stage. In the anger stage, a person resists the loss. The person is angry about the situation. They're angry at the person who died. They're angry at themselves. They're angry at the healthcare workers. Sometimes they're angry with God or their spiritual being. And you, as a healthcare professional, you possibly could be the object of this anger. And so I just want you to be prepared for that. And usually it's not a dangerous place to be, but I just want you to be prepared that you don't have to be yelled at. You don't have to feel unsafe. Bargaining is when the individual postpones awareness of the loss and tries to prevent it from happening by making deals or promises. And the best example I have for this one is sometimes you'll hear somebody say, you might hear somebody say, "If only I can live until Christmas. I just want to live until Christmas." Or if I can live until this baby, my grandchild is born, something along those lines. That would be an example of bargaining. During the depression stage is when a person realizes really that full significance of loss. And the person could feel overwhelmingly sad, lonely, and maybe even will withdraw from interaction with others. You can kind of picture that one, an example of somebody curled up in bed or just not able to get through their day-to-day lives during this depression. And then acceptance is the last stage, when an individual begins to accept reality of the loss and the inevitability of the loss and starts to look to the future and understand that this loss doesn't have to define them. So when we are dealing with patients who are dying, there are some things that happen at the end of life that I think we want to talk about. And so when we get to the signs that a person is near death, it can help if we educate family members what to expect and what would be normal. So on the screen right now, we have some signs that a person is near death, and these would all be considered normal. They may sleep more. They may talk to people who you cannot see. They may talk about taking a trip or leaving. They may withdraw and have very little to say. They will eat and drink less. They will probably have trouble swallowing. They may become more and more confused as time goes on, even from hour to hour. They might make moaning sounds. They may lose control of bowel and bladder. Their respirations might be different. It might have some congestion sounding or have those long periods without breathing, followed by several quick breaths. Their vision may change, and they may not hear as well as usual. They may actually have less pain and require less pain medication, or they might not. It depends on the situation. Their limbs may be cool to touch, and they might have some cyanosis around the lips and the nose and the fingers. They may be, if the patient is restless or seems anxious, that is definitely a reason to take a look at the patient and try to assess pain if you can. Sometimes family members will be afraid of these changes, and so it's important to talk to them and talk about it. It is probably the patient can still hear you, even if they're not responding. So talking to the patient, singing or listening to music can help. Even if they seem a little bit agitated, sometimes those things can help a dying patient to become less agitated or even a little bit less confused. Our second theorist is Bowlby, and there are 4 phases of mourning, and attachment is the first one, and that's the behavior that leads to lifelong bonds of affection. And this was specifically talking between children and their primary caregivers, so parents and their children. Then in the numbing phase, this is when the loss has just occurred, and the person who has had the loss has extreme emotion and might report feeling stunned or numb. And this phase can last. They do put a time on these, but it doesn't. The timelines don't fit everybody's style, so just be aware of that. But typically this numbing phase lasts from several hours to a week. Then we have the yearning and searching phase, which evokes emotional outbursts, tearful sobbing, and acute distress. To move forward, people need to experience this painful phase, and it can last for months or intermittently for years. They can have the physical signs and symptoms of grief as well, and I think I'll go through those later. And then during the phase of disorganization and despair, this is when the person who's had the loss spends a lot of time thinking about how and why the loss occurred. They can express anger at anyone they believe is responsible. And again, you may be the target of that anger. And gradually, this phase does give way to acceptance that the loss is permanent. And then they enter the final phase of reorganization, which usually requires a year or more. And the person accepts some unaccustomed roles because of the loss of the other person. They acquire new skills and start to build new relationships. Worden's model was developed in the 1980s, and it suggests that people who mourn are able to actively be involved in helping themselves. And this also gives a time, a year or more. So the first task that somebody who has had a loss needs to have is acceptance of the reality of the loss. So, oftentimes that first reaction is disbelief and surprise. But in this task, people start to accept that their loss is gone and will not return. The second task is to work through the pain and grief, that it is impossible to experience a loss without some degree of emotional pain, and that individuals who deny or suppress their pain often prolong their grief. The third task is adjustment to the environment, in which the deceased is missing. So, if you're very close to somebody and you lived in a house for 20 years with them and now that person is gone, that's an adjustment to make in the environment. And it can often take several months to really get the full impact of the loss of that person. After the first few weeks after a death, visitors and friends become less attentive, and a person's experience of the full loss becomes more impactful. And then adjustment happens as a person takes on new roles that were formerly filled by the deceased person and starts to participate in new activities. The fourth task is emotionally relocate the deceased and move on with life. People who move on do not forget the deceased or their loved one. They do not devalue their relationship, but they do begin the task of giving up the deceased or giving them a less central place in their life because they're not there. And eventually a person is able to love other people without loving the deceased person any less. We have some different types of grief, and normal, uncomplicated grief consists of commonly expected emotional and behavioral reactions to loss. Anticipatory grief is the process of letting go before an actual loss or death has occurred. And so a good example of that would be of a person who maybe has diabetes and heart disease, and they know they're going to have their leg is going to be amputated. So they could be going through some anticipatory grief over the loss of that limb. It could also be, you have a loved one in hospice and you know that the end is coming, and that anticipatory grief has begun. Complicated grief happens when a person has difficulty progressing through the loss experience and they're not going through all those stages that we talked about. A person experiencing complicated grief feels strain in relationships and finds it hard to go forward in life. Disenfranchised grief is kind of a dual experience when somebody cannot openly acknowledge a loss and they cannot receive full social support from others because they won't allow themselves. This type of grieving is difficult to understand. It occurs in situations in which others view a person's loss as insignificant or invalid, or when a loss is deeply private or secretly experienced, such as a miscarriage, or maybe death of a family member as a result of drugs or alcohol, or even suicide. I think now people don't keep those things as secret as they used to. But again, in some cultures, it might be less open than our typical American culture. Some variables that influence loss and grief. We have several here. The first is development, the developmental stage of the patient or the individual. Obviously, a cognitive ability would affect how the understanding of a loss. And you think of how a 4-year-old compared to a 14-year-old compared to a 44-year-old, maybe they all lose the same person, but they understand and react to that loss all differently. Older adults can have some complicated grieving because of multiple losses or multiple losses at the same time, with their accompanying functional decline, inability to attend grieving services, things like that. While we're on this topic, if it's a patient going through grief and they're taking pain medication, that is going to affect them cognitively as well. And so we need to take that into account. If are they cognitively aware? um, psychological perspectives on grief and loss. Sometimes coping mechanisms are not the best for a lot of patients, and people need to find new coping resources and be able to maintain some control and stability. Socioeconomic status has a big influence on loss and grief because of expenses, because of lost income. This can make loss and grief more difficult and more complicated for people. The nature of personal relationships. So, how close was this person to me who is gone? An example of this I can think of is I still see people with Dale Earnhardt stickers on their cars, and they felt very close to him, even though he was physically probably not close to them. The next one is the nature of the loss. Was it expected or unexpected? In addition to social stigma, as I mentioned earlier, alcoholism, drug abuse, things like that might cause people to grieve a little bit differently. Here comes culture again. This can help provide structure and interpretation of coping for people and ways to cope with change and loss. And we need to remember that we need to respect culture and cultural communities, and maybe have specific rituals around death and dying, that even though we are not familiar with those rituals, we are respectful. And one example of that I used to see in the news a lot was Ebola patients in Africa. When those patients would die, they would be whisked away, and they were either burning bodies or burying them right away and not allowing any funeral rites for those patients and their families. And that was a barrier, and it would actually scare people away from seeking treatment for Ebola. And that was one reason why it was spreading until they could educate people on why they had to do it that way. And then spiritual beliefs, those rituals, practices for coping are very important for people. As a nursing student, and certainly as a nurse, I would expect that you are going to have some personal experience with loss. So if you have not had that already in your life, this is a great chapter and information for you. You will think of death differently after becoming a nurse. You will use your scientific knowledge and be able to learn how to help people through these tough times for them. So part of our nursing process is assessment, and we want to make sure that we are always beginning with an open mind and being accepting and humble. When you are helping a patient through death and working with the family through this difficult time, they are going to remember you, and they're going to remember what you say. And so listen to what they're telling you. Make your suggestions, help them through it emotionally. It is important to determine how people are grieving, what stages they're in, what type of grief or loss they're experiencing, and that can help you figure out where to go with that person. Your assessment becomes more specific as you begin to observe their behaviors, listen to conversations, and identify where they are in the stages of grief and loss. One of the things you can look at is if they're having physical symptoms of grief. So are they having those typical grieving feelings, sadness, anger, depression, numbness? Are they having some different types of thought patterns, disbelief? Are they confused? Do they seem preoccupied? Are they really in an attitude of despair? Do they have the physical symptoms of grief where they have tightness in their chest or in their stomach or abdomen? Maybe they don't want any loud noises. Maybe they feel short of breath, or even might have some of those symptoms of panic or high anxiety. So short of breath, can't catch their breath, dry mouth, racing heart. And then what are their behaviors? Have they gone through a lot of sleep changes, appetite changes? Are they not eating? Are they eating all the time? Are they having bad dreams? Are they crying all the time? Are they walking around with an object that belonged to that person? Or sometimes in a movie, you'll see somebody's walking around with the urn of ashes. And that can help you kind of assess and help people get to where they need to be. Assessing the coping patterns. What resources does the patient or family have to cope with loss? Do you need to help them with advanced directives or power of attorney? We'll talk more about that in law and ethics. And then looking for those older adult issues of multiple losses, depression, all those things are part of your assessment. Some common nursing diagnoses: death anxiety, ineffective denial, fear, grieving, hopelessness, risk for loneliness, social isolation, spiritual distress, readiness for enhanced spiritual well-being, compromised family coping are just some examples. Palliative care is focused primarily on managing distress caused by unwanted symptoms of disease or side effects of treatments. This can include curative care. It does deal with quality of life issues. Hospice care provides service for patients who are really at the end of their life. They don't want any curative care. They want treatment of symptoms only. Typically, they will have 6 months or less to live. And the goal for both is to maintain a high quality of care. When we're having our nursing implementation with patients and family, we always want to first and foremost use our therapeutic communication, keeping in mind that people are going to have those intense emotions related to their loss or their grieving. We want to promote hope and spiritual well-being. We want to facilitate mourning and give people a way to physically grieve over their loved one, whether that be with their religious rites or family traditions, however that can help somebody. Manage symptoms. So we talked about symptoms, physical symptoms of a patient who is dying, or also the symptoms of grief that we talked about earlier. We want to make sure that we're creating a comfortable environment, that we are assuring people that they are not going to die alone, be readily available to answer questions or interpret changes in patient condition, encourage family members to visit and try to relax those visiting restrictions and allowing them to stay overnight, etc., if possible. Signs of impending death: when you have an absence of breathing and heartbeat, bowel and bladder release, the patient is unresponsive, and the eyes are fixed and the pupils are dilated. After death, you can help family members notify the funeral home, other family members or friends who are not present, and help arrange for transportation of the body, gather the patient's belongings. If you're in an area where you should talk to family members about organ donation and procuring organs, that would be the time to do it is fairly quickly. The best time to do it is before death, but if that's not possible, then very quickly after death. If the patient left no communication about wishes regarding organ donation, the family can make that decision. Care of the body after death is very respectful and quiet and solemn. All tubings are removed where possible. Cleaning the body, leaving dentures in place if possible for just a natural appearance of the mouth. Close the eyes if possible. Sometimes if that can be a problem, and if that is if you feel like you need to, you could fold up a washcloth and just put that over the eyes. There are some state laws that require healthcare agencies to have their policy and procedures to validate death, and that in many cases, but not every case, that requires a physician. However, in hospice, that very often is the nurse. And autopsies are not really that common because they're costly. But if there's any suspicion as to cause of death, then you would definitely need to call the police and let them just make that decision. Of course, you document all of that process as you go. So one of the most important things we do when we're dealing with loss and grief is that therapeutic communication. So practicing that and examining how you go through grief and loss can help you experience that loss and grief of a patient in a different way, in a professional way. And it's not always easy to do that, but make sure that you have your own support systems for when you start to feel that loss, and finding what's within you to withstand changes like this when you're dealing with this at work. Lots of value and satisfaction in helping people die and care for loved ones and helping people get through this. I always say those nurses who do this all the time are super special.